For the next session on money, the devil or the dear Lord, we're going to discuss in France who pays for what. So I will call now Didier Bazouki, Bertrand Mas, Philippe Prel, and Nicolas Revel. And the moderator will be Thomas London. Hello. So in France, who pays for what? The question as it's raised is in the present. So now I propose that we debate the advantages and drawbacks of our system of healthcare coverage in France, which is very specific, we must admit, with several levels of the system. And then it will be interesting to debate on the progress that we can make and the improvements that we can make. So in recent years, we've heard about a lot of systems making serious, significant changes. The Germans opened the possibility to insure with private insurers for the first euro and to, in effect, go out of the public system. The Dutch have privatized their healthcare system recently, and one of the key objectives is to improve, with Obamacare, one of the objectives is to improve general health coverage for the Americans. So, Philippe Prel, you're the head of R&D at AXA France. Didier Bazouki, you're the managing director of Covea Santé Prévoyance. Dr. Bertrand Mas, you're an anesthesiologist at the Hospital Saint-Joseph in Marseille and president of the group Pasteur Mutualité. And finally, Nicolas Revel, the managing director of the National French Health Insurance System. But what is this healthcare coverage system? What is its purpose? Well, the first objective is to socialize the expenditure, and a value that is very dear to the French system, to guarantee that all have an access to healthcare depending on their needs and not their means. So that's what I would call allow equitable access to healthcare. But that's not the only objective that we assign typically to the healthcare system, the health insurance system. There's another one, which is the improvement of quality and the productivity of healthcare institutions and services. So the benefits received with respect to the cost. So in Obamacare, if you look at the first objective to enlarge healthcare coverage to the population, they also have many reforms around accountable care organizations. So the goal is also to stimulate the productivity and improve quality. And the third objective is to encourage the adoption by citizens, the insured, of beneficial behaviors for their health and to be attentive to the value of the health care they consume. So, in other words, responsible behaviors. And we're seeing a certain number of services emerging, including in France, reimbursement, encouraging people to do more sports, etc. So, given these objectives, and what do you think we could do to meet them even further? But first of all, I'd like to ask you, if we had to explain to a foreigner the advantage of our system, our multi-layer system, what would you say to a foreigner if you had to explain the French system? Well, tell me if it should be, if I'm speaking to an Englishman or a German, because we had a debate this morning about that. What you could say is that we have a system of social protection that basically has worked well since the end of the Second World War. It was created in the framework of the welfare state of the 1950s and 60s. Today, almost all of French residents are covered by the national health insurance. 80% of our fellow citizens have complementary healthcare coverage in addition. So we have a system that broadly covers most of the population. We always talk about the basic healthcare and then the complementary healthcare in France. But it is a system that has an important quality, which is that it's the remaining money that the patient or the healthcare consumer has to pay. This remaining amount is very low. That's the final amount. The final amount that is one of the lowest in the countries in the OECD, because we're the third last, just after Holland and Turkey, I believe. So we have one of the lowest final costs for patients. It's about 8.5% of the total expenditures. Social Security covers 78%, and the complementary insurance plans cover about 14%, and they're about 8 or 8.5% for the final consumer. So this remaining amount is very low. And that's an important element in terms of accessibility to health care. Of course, there are some caveats, but the system has worked quite well up until now. Now, it has to meet a challenge of sustainability of public expenditure, in particular with the future expenditures on new molecules and new therapeutic solutions. There's also a demographic challenge. There are new professions with the arrival of digitalization. So these are new jobs that are developing. And how are these people going to be protected in the future for their retirement and for their health care? And also, there is a challenge of accessibility that we can discuss, because this is a debate often between the mandatory portion and the complementary portion. Now, if we come back to this point, and perhaps to start, up to what extent does our model meet these three objectives that I mentioned, starting with this notion of equitable access to healthcare? What is the real performance of our system from this standpoint? Well, I would say that overall, it's effective, but we have to distinguish different cases. For example, if you take emergency wards and heart attacks and strokes, it's better to be in a large city for that type of thing. Now, if you look at oncology, frankly, everyone has access to a very high level of care. And it's in terms of planned surgery at the hospital where we do see some problems of lead times, but it's not as catastrophic as what we can see in other countries, such as the Nordics. So I would say that despite this, it's still quite reasonable. And we do have alternative solutions between the private and public sector. But nevertheless, it's true that we have an objective I think that we all share, which is maximum equality, equal access to health care. And I think we have one of the most egalitarian systems because everyone has a free choice of their health care. Very few countries have this free choice. And so through this freedom of choice, some may exercise it more than others, and we know that those are often the most educated, cultivated people who will benefit the most. That's a reality. But that shouldn't prevent us from continuing to help people. We want to set up networks where we're allowed to do so in optical or dental care, for example.
So, as a payer, all of you, what can we do to improve this access? It's good for a certain number of things, but we're also seeing that there are a certain number of specialities, perhaps places, where it's not quite the case. And we have things that tend to deteriorate in terms of facility of access to certain types of specialists. To what extent, you as payers, can you act? Just a few words to add to what's been said. And tell me if I'm getting it wrong. It seems to me that our system is deficient when concerning the remaining cost. When we look at outpatients and private practitioners, less covered by health insurance with a remaining cost that is higher in dental and optical medicine, this is what we see. So that's the first thing that I can add to the debate. Any reactions to that? So I'll finish. So the specific aspect of our system, if we had to explain it to a foreigner, is that we have that double layer, a layer for obligatory health insurance and then the layer of complementary. You've figured the costs, you've cited the costs, 70% for the obligatory part. It's fairly stable. It's been stable for the past 10 years. And then even if we can discuss its efficiency, it does have a certain number of success stories. The remaining cost is 1. It's 8.4, and it's going down year by year. It has been going down for the past 3 or 4 years. I think it's also an advantage of our system to be able to cover heavy pathologies. And when you say that when you look at what the coverage rate is for common health care for small illnesses, we can arrive at that figure where the national health covers a little over 50%. One might say it's not very much, but it's what we find in private practices. These figures, this figure stands out from the hospital and long-term infections. So patients who go to see private practitioners, they go to see the doctor for a bronchitis. But what about the rest of their life? If you have a long-term pathology, 94% of your costs are covered. Even if today a little over 10 million people have long-term pathologies, 8 French people out of 10 end up with a long-term infection. So I think this is something that has to be taken into account. It raises the issue of sustainability, but up until now, even if we might be afraid of sustainability, we have to wonder about it. But nevertheless, the system is based on universality and equality. That's been maintained. The principle of freedom, free access to your doctor. You are allowed to choose your doctor. And the balances are getting better, and the expenditure, it's something like 2% a year. And when we compare that to other countries, we're not doing so badly. So several of you are saying this, are talking about this remaining cost that is low and saying that it's an advantage. The Swedes have 16%. That's the remaining cost for the Swedes. I think they manage health well. If we were to encourage behavior focused on value as an objective, shouldn't we coordinate things more specifically in relation to the remaining cost? When you look at the way it's shared out, for example, so people who don't have additional health insurance, they can't really pay for the additional cost. Shouldn't we therefore be coordinating it better and make it into a tool for inciting people to adopt different behavior? And if we think that it's like this, maybe we need to increase it in a targeted manner for other populations. Let me say something about that. Let me talk about the remaining costs. We often read things that are wrong. We confuse this remaining cost for national health and the final remaining cost. Let's remember that 96% of our citizens are covered by additional health insurance. So this shows that the social protection pillar, the national health system in France, has an obligatory side to it and a complementary side to it. Let me give you some figures. I don't want to give you too many figures, but let's talk about the remaining cost and show that the additional part is a determining factor for smoothing things out and pooling the risk. We carried out a survey on 1.5 of our insurees on their hospital stays, short-term stays, psychiatric stays, medium-length stays, and the remaining cost for the national health before we intervened is something like 5,200 per person insured. So for one out of 100, it's 500,000 euros. Now, of course, when the health insurance companies, the private health insurance companies become involved, for 80% of the people, the remaining cost is 0, and for the other 20%, it's 26%. So it's an advantage, therefore. So the private health insurance and the national health system take this risk into account, and the additional health insurance companies play a determining role in terms of pooling the risk. But it's the same for LDs. We hear ministers talk about patients who didn't need additional health care insurance. Statistically, it's true, but individually not. A person in LD has a cost. It's double that of another patient because they are covered because of their long-term infection, but there is peripheral health care that means that there is a lot of additional cost. And this has consequences, as we will see later. So it's important to have that additional health insurance coverage. Yes, it's important to be able to pool the risks, but should we be pooling all of the risks? Should we be targeting a 0 remaining cost, or should we be coordinating things a bit differently? 10 points, that's 25 billion. I think there are two things here. If I'm hearing in your question, the right path is to reduce the healthcare covered by national health, I think it's something that can be insured. And the additional health insurance companies would be delighted to come and cover that additional risk. It's their job after all. And it is also what insured people might aspire to. But we've got to be cautious. There are two things that we need to think about. Is the basket of healthcare, is it balanced? And I'm talking about the obligatory national health. That's the one I'm most familiar with. The additional health care systems are multiple and varied. If we have to think about the basket of healthcare, not to reduce it, but to redistribute it, there are other questions that should be asked. I think today, the remaining cost that is the lowest is for healthcare transport. The highest concerns dental healthcare. I'm not saying that the subject is simple, because there are many people who need health transport. However, I'm not sure, I'm not convinced, maybe I'm anticipating here on the debate, when we talk about the question of sustainability, should we regulate it through the disengagement of national health? I'm convinced that there are there's a certain amount of room for to find more efficiency, and we need to involve patients with that. That is a driver, just like the right organization of pathways or better efficiency in prescription. The involvement of patients is one way of going about this. Does it mean modulating management health coverage rates? That's a different question. Maybe we'll talk about it, but it's complicated. So if we come back to the idea of improving productivity and quality of healthcare services, once again, to what extent the model that we have today, to what extent does that model fulfill the objectives? And if we're caricatural, we've got something that is split into four. You've got the two-story coverage, and then you've got this dichotomy that we hear between private practices and hospitals. We have regulation that today is globally promoted by the public sphere. It's carried by the public sphere. One of the subjects of the roundtable is, could we not make a little bit more room for private financiers who would like to be more involved in regulation? We've got a public sphere that regulates, and it's not just healthcare, the national health system. There's a sharing of responsibilities via the hospitals, ministries, health insurance companies, regional health authorities. So it's diverse. I think it works globally very well. It works on prices, but it should try and obtain efficiency gains by looking at the different pathways, the healthcare pathways. What about the role for additional health insurance companies? I think this is something that we hear about again and again, but it's complicated. It's not because it's a question of principle, but when you have a system to be regulated, where you have a major financier, over 60%, the regulation taken over by the private insurance company must be consistent. There must be coordination, without which it's going to be complicated for healthcare professionals and us, and for the legitimacy of the tools implemented. And coming back to consistency, to be able to coordinate from the partners, from the private and additional health insurance partners, they've got to be part of global coordination programs. And this is what I'm seeing through the functional negotiations that I lead with the complementary partners that are part of the UNCAN. There's a certain difficulty promoting strategies and points of view that are global and collective. Fundamentally, you are companies and you manage contracts. Oh, we need an answer to that, definitely. So that you're right with the basket of healthcare that we've got today. If you imagine that for optical medication and healthcare, we take into account everything. we're not seeing the necessity for this subject. There's regulation that is very specific that tells us how we reimburse. It's the case today because the decree, I've got it here with me, it's 40 pages, so it explains how in relation to the guarantee, optical actions have to be reimbursed. But all of this is absurd. When you see that some expenses come from the public sphere, are part of public interest, then have to be regulated by the public service, the national health system. When patients, people who are insured, are allowed to make free choices, then they've got to be allowed to subscribe to programs that are more or less covering their needs. Now, there are things that mustn't be done, definitely, and perhaps we'll come back to that later on. The regulation that applies to us today has become extremely bureaucratic. We talk about the additional health insurance companies, but they can't do anything more. We've created a number of healthcare networks, especially for optical matters, and they've been successful. As far as we're concerned, 2/3 of our insurance people, when they go to our approved networks, the rate is 40% lower than the average market price. We've got 96% satisfaction of the people who are insured. So what more can be said? We haven't been allowed to do anything else in other sectors, and that's where there's a real problem. Yes. Bertrand Mas. Before talking about additional health care insurance as part of the coordination of healthcare policies, one might ask, when we listen to these debates, what we've been hearing since this morning, current medicine has changed, it's no longer acute, so we're talking about healthcare pathways. There's a necessity to get rid of these silos, the hospital on one side, the private practice on the other. We can say that if we've got to break up these silo-based financing systems, and this is an idea that I'd like to introduce, if we break this up, this silo-based governance, perhaps we'll be moving towards some kind of merge. The CHAM with the DGOS, for example. These are things that we're hearing about. We're hearing people say this. Now, I know that we can never really reform and start from a blank page. We've got to take into account history. But it's not absurd to talk about this. We've been complaining since this morning that we've been complaining about financing. And we've been complaining about governance and coordination. Yes, it's true that we need to widen the debate. We can't do regulation just from the point of view of the remaining cost. It's true that in other countries, the question of the budget comes up. The budget is managed by healthcare professionals, by healthcare centers, and it's fundamental to be able to develop that kind of thing. The assessment logic is essential, and we can come back to that when we talk about quality. And there are also these new practices. I was a bit disappointed personally for telemedicine, and the agreements don't take this into account. I think it's a practice that really has to be developed. And given the debate, what we want to gain is some kind of room for maneuver to be able to innovate and provide new services for people. Before we move on to the organization and the rates, let's just stay with the question of drivers for or enablers for additional healthcare insurance companies. What are the drivers for managing risk that these additional healthcare insurance companies might use? I'll start. Well, we often hear that with 13.5% of expenditure, you shouldn't regulate the system. Well, I can understand that. However, it's a statistic. It's not the situation in which our insured people find themselves when there is some kind of expense for hospitalization. Before the additional healthcare kicks in, you can examine the fact that when one of our insurees go to consult a doctor and the price is increased by 30%, the additional healthcare system pays more than the national healthcare insurance. So it might say, well, when I have to cover this need, if I'm the main financier, why can I not set up agreements with the profession, the medical profession, the dental profession, to be able to do this? Now, we can do it today, but we can't do it with doctors. I don't know why. We can do it with certain professionals, but not with doctors. Very surprising. And maybe the CNAM has an answer to this. First of all, it's about giving back the legal possibility to communicate. It's not your fault, so you can talk about it freely. Don't mind me. No, first of all, give them the ability to talk, to negotiate, to set up contracts with the medical profession first. Then you have the responsible agreement invented in 2004 for some very bad reasons. It started by obliging us to pay out a number of reimbursements for services, basic services. This was a strange idea because our insurers, they need to be free when it comes to risks relating to hospitalization or gastric flu, but they're not allowed to make that choice, which is strange. And more recently, there's the new contract, the responsible contract that has emerged with ceilings and thresholds for medical acts and optical acts. So contributions are increasing because the thresholds are making the risks even worse, but at the same time, we can't reimburse excess costs. We can't reimburse, and they don't understand. The people we insure don't understand the guarantees that we have to take out for optical acts. The document is absolutely incomprehensible. It's not something that we can explain to our insurees. So there's a problem of readability. There's a problem of acceptability. We would have preferred to undermine the credibility of additional healthcare insurance companies. So we need to have solidarity with these two pillars that we've been talking about. We need to forbid the selection and exclusion of risks when we are part of the social protection system as an additional healthcare insurance system. We should not be able to select or exclude risks, obviously, and I think the whole profession agrees to this. However, we need to have more room for maneuver when it comes to the ability to respond to specific needs, the specific needs of certain insurees who only want to be insured for high risks. So we need to have prerequisites that allow us to work differently in the future.
So I'm going to go quickly through the decree that doesn't put a ceiling on dental care, only on medical care. And the fact that there was a ceiling was a strong request that came from a lot of the additional healthcare insurers. Some of them, but not a small part of this complementary healthcare insurance. So let's talk about the health networks too, and why are these health networks legitimate? You've described that quite well because you're almost at 100%. Why is it beyond when you're not in the majority? What is the healthcare network? What underlies it? It's the fact that you're proposing to the insurees to get more or less good treatment depending on who they go and see. It's the basic care, and they get better care if they go see the healthcare professionals in the network of the additional healthcare insurance companies. It's an incredibly powerful driver. So when we go buy a pair of glasses, we consult the internet to see which opticians are approved. It's a very powerful tool for the healthcare professionals. If you want to have patients the same number, you're going to have contracts concerning prices and quality. It's such a powerful instrument that the national health insurance doesn't have it. So we can say we could work on these networks if we're not at 98%, if our share of financing is at X amount, a small amount. This raises a first topic in that we're shifting the main regulation instrument from the minority insurer to the multiple one. You're not just having one contact person at the national health care that we negotiate with, but we're actually proposing something quite different. Do we move this type of regulation into the hands of 400 different operators? And this could prevent people from choosing their healthcare professionals. So this means that national representation today has considered that this could not go beyond the healthcare positions where you're already a majority shareholders. So if in future we had to consider that we need to go towards these health networks, I think this could be of interest, of political interest, but it has to be coherent in terms of how we finance healthcare in France. I think we need to make the difference between what is the distribution of medical goods. You talked about eyeglasses, and also medical acts. They cannot be dealt with in the same manner, of course. Earlier on, I mentioned our results. 2/3 of our policyholders who get glasses use the network. And sometimes they'll drive 50 kilometers to take advantage of the quality price advantages. So they can stay outside of the network. They're slightly less well reimbursed. They're still reimbursed, but they'll have to pay a higher level of the remainder payment because the optician will not have signed an agreement on price or quality, so they can invoice a market price, which is usually 40% higher. So the restriction of liberty is not real. It's just a rational choice of the economic actor that is the policyholder. But we can't treat medical care the way we treat optical care. There's a lot of comfort that's involved, also fashion that plays an important role. Whereas if we're talking about medical consultations, they're technical actions and technical acts, and they're not the same, and we need to take precautions. But rather than talk about these topics and see what types of limits can exist in health networks, medical health networks, and not the distribution of goods, they've forbid all of them instead of making the difference. Yes, we all want to do the same type of thing. We want to avoid what we're regularly hearing from our patients who end up with very high invoices and estimates for surgery that are really excessive. But they're exceptions, that really strike people. And sometimes we manage to solve them with our social actions. We find other funds, but this is not a solution. So if it's the medical agreements, the CHAM, or the networks, we want to be on the patient's side, and that's really our will, to help the patients as much as possible. I represent Astel Mutualité, which is mostly health professionals, private practitioners. We're not in favor of the medical networks, and I think most of our patients aren't either. When we talk about health networks, we're talking about one of the tools to regulate offer. I don't want to go through the alpha and omega of the regulatory tools for productivity. There are other ones, and this is a field in which we're seeing a lot of innovation in the world. We talked about the US earlier. There in Spain, we're starting to see payments per episode. We're getting capitation, payment per result. So there are lots of innovations, and the reinforcement of regulatory tools through the quality of the offer. So what could we do in France beyond the debate about networks to have better tools to regulate offer? I think this is going to be a very important topic for the future. We haven't fully associated the complementary health insurance yet, but for the public payers, the regulators, when you said that we have financing and governance in silos, that's true, and it blocks innovation, not therapeutic innovation, because we know how to foster this and assess it. But organizational innovation, which is highly dependent on financing, that comes from the mono-professional, that comes in to pay structures or health care paths. So these are things that we need to examine, and we don't have the appropriate tools today. Beyond the questions of the boutiques, little shops, our financing tools are too rigid to take this into account right now. So if we stay within the sphere of public financing, this is something that we're going to really have to work on in future. And I'd like to just say a few words about telemedicine. The medical agreement, the medical convention that was signed in August, does not really open up to telemedicine. There's experimentation that was set up by the law. In France, to start experiments, you have to go through the law, legal basis that takes time. And it concerned 9 regions. I think in the next one, it will be extended to the whole French territory. But in the negotiation, it was considered that we should move ahead on this, and so we will open telemedicine to the residents of medical homes, and we'll open it up on the treatment of 2 pathologies, which are heart failure and another. So you raised a point that slowing us down in social innovation, it's our obsession with pilot projects. We're trying to constantly find proof of the concept, and I think it's time that we moved on to more action. And I would add to that, on the industrial side, we have to be vigilant. We know that today, 50% of companies working in finance and insurance are based in London for all of the European Union, and the English are setting up something quite intelligent. They call this the regulatory sandbox, that within an experimental framework makes it possible to do what the Californians have been doing for many years now, so to go beyond regulations, to ignore them in order to experiment. We can't do that. In France, we explain to the complementary health insurance that they can't do anything. And so why not imagine that with the regulatory sandbox, we could open up some topics. Let me give you an example that shows where we stand today. With the Pharmaceutical Lab that's present here, we wanted to become a sponsor of to detect patients with BPCO. We selected 2 pilot regions. We negotiated with the authorities. It's not just for your policyholders, it's for everyone. That was fine. And in the end, we obtained support from 2 regional health centers and the corresponding organizations. So we were happy. It was required a lot of investment, and we were prepared to do this because there was interesting experimentation on this. For the complementary health insurance, it was good because studies showed that there was an interest on paper for both health regimes. So it was a great convergence of interest. So we still haven't launched the operation because for a wrong motive, the CNIL did not allow us to do this. So we're now in front of the courts. Is that reasonable? The English are doing the opposite. Let's stop over-legislating. So just about innovation and piloting projects, we, as in mutual insurance companies, we have our own funds. We sometimes have funds that we want to invest in a more risky way on innovation. And the regulatory constraints in terms of solvency means that these funds have to be extremely secure. It's a bit technical, but it means that we can't be the drivers of innovation in the way that we would like to. We've got 2 minutes. So if we want to try to change the behaviors of our policyholders, to make them more responsible to what they're consuming, and to encourage them to have healthier behavior. So the idea of the extra ticket to pay is something that we can use in a precautionary manner, but we're seeing a lot of examples in France and abroad of incentive programs, strong incentives for patients. So what do you think of this, and how far can we go? So very quickly, why I'm against it, a little bit against it, and very much in favor of it. I'm a little against it because on an ethical level, it doesn't correspond to our way of seeing things in France. If in a utilitarian reasoning, when part of the population does good things, it's good for everybody. From the freedom standpoint, people are free to do what they want. It's the principle of dignity. So we can't use these types of means, and you can't sell organs, for instance, and you're not considered to be undignified because you smoke in France. And so that's why I think we need to talk about ethics in the idea of rewards. Just how far do we go? Now, on the plus side, what I'm in favor of is that we're trying to change people's behavior. I'm a tobacco specialist. There are a lot of failures when you get people to change their behavior. But what you do see, I'm a swimmer. Now I choose my hours because a lot of people swim. 10 years ago, I would go to the pool and I'd be alone. So what am I trying to say? Prevention has a fashion effect. The more we have these actions, even if they have a modest effect, they still have a real impact on society. Like Philippe, I'm a bit against it, but I'm also very against it. Why? In our group, in damages and responsibility, we know that behind the wheel behavior is responsible for most accidents, and that's why we have the bonus malus. We think this is a bad idea for health, for an ethical reason, but also a fundamental reason, and that is that studies have proven that when you determine the health of a population, behavior is only part of it. You have environmental effects. Not everyone chooses their health. So there are genetic elements also. So for all of these reasons, since behavior only has a minor impact, we think it's very dangerous for a social protection agency, which is there to add to the national medical regime, would be dangerous. It's unethical, and it's very linked to the nature of our social protection system in France. Thank you for that analysis. The debate is not finished yet. We can come back to this another time. Thank you.